The pleasure of discussing South African scheduling for CBD and THC with my guest, Jacqui Ramage. She's a responsible pharmacist who I met about 2 years ago at a GP's Expo as well as a pharmaceutical manufacturing expo. And welcome, Jacqui. I'd like you to maybe tell the audience a bit more about yourself, your journey as a responsible pharmacist and how you got into, cannabis ultimately, which probably at the time was a bit contentious as coming from an RP background. With the need for more clinical evidence, but we're both very passionate about this, and I'd love to hear how you came into the plant.
Morning, Jeff. Thank you so much. As always, it's wonderful to have a discussion with you. Jeff and I have traveled a long road since we first met at the GP TPS Expo, and we've maintained and continued our discussions around cannabis and analytics and regulation, I think, as a broader picture. So I studied pharmacy at Potchefstroom University, which has now become the University of the Northwest. We were actually, our group were one of the first English-speaking students to be getting Afrikaans lectures with English textbooks and writing Afrikaans exams. So it was quite an exciting time. And if I have to incorporate it, I gave it a little bit of thought later, is that it was already sort of disruptive then in a long-standing profession. So I was almost setting up my timing for being a professional within a disruptive industry, which I think this is where we sit right now. And serendipitously came into cannabis because I was diagnosed with breast cancer 4 years ago. I went through the whole chemotherapy, radiation, double mastectomy journey, and there were a lot of discussions around cannabis, and there always have been discussions around cannabis, in whatever context we were in as students, or if you were in a pharmacy, in a regulated environment, in a law-enforced environment. Medicines are very strictly controlled, strongly regulated, as they should be. And along came the changes of the cannabis regulations, and I had then been approached by a number of clients to then consult. So I've consulted. I have a strong background in cultivation knowledge, in setting up facilities, as well as analytics. And my passion still remains the patient, though. And I'm very glad that every morning when I check myself, that the patient is still my ultimate goal. We ultimately go into this profession to help people, to nurture people, to make people better. Any healthcare professional, their origination comes from a need to help people, and that's essentially what I would like to continue to do in the proper way, in the guided way, but in a typically disruptive industry. So yeah, in short, that's my little bio. I do also have caveat is that I do some clinical evaluations for SAHPRA, but because of a whole bunch of lots, like I told you about Professor Mark Blockman, his conflicts of interest and his disclaimers are just lots. So I will speak in the context of public domain, and we will go from there.
Perfect. And public domain is definitely where we're going to be focusing. Is at the end of the day, my care is also with the patient and the consumer. And for that reason, I find it vital that there's more information available to the public. And with that intent, we've basically focused heavily on the production of content, relevant content. The discussion on scheduling, I feel, is more and more important as we see individuals coming to basically market with products. And we want to make sure that, it's important to push the boundaries in the space. If we're waiting for regulation and it's taking a bit long, it's an important need to, start to get products out there. But I also want to keep consumers safe as well as those individuals from overstepping. And this is why I think it's necessary to have a discussion around scheduling, what it means, so that the public as a whole have a better feel for that space. So in light of that, the main discussion we're going to focus on today is obviously the distinction between the schedulings, whether that's Schedule 6, 4, or Schedule 0. In that regard, I think it's nice maybe, Jacqui, to bring you back in just to briefly discuss the Medicines and Related Substances Act. Where did it originate from? What was the point or the purpose behind the Act? Because ultimately, a lot of this is put in place to protect consumer safety, and maybe you can speak a bit to that.
Sure. Jeff, so Medicines and Related Substances Act 101 of 1965, it had been in working for quite a while in terms of our industry. Healthcare, and specifically the regulatory industry, is very much of a prospective view on what people or what patients and what healthcare professionals should be doing. So, it's not like suddenly, I often liken the industry to the tech industry, is where the tech industry has come so far ahead that we've now been making retrospective laws and retrospective regulations regarding social media. I mean, one of the examples I can think of is, can you get divorced on WhatsApp or via social media? Suddenly, the lawyers, the social media, and the tech lawyers had to think about that, because that's what people were doing. And the Medicines and Related Substances Act came into that prospective regulation in terms of the laws around medicines, the laws around excipients, the laws around who can handle what product, who can dispose of a product, who can prescribe a product, who can be a custodian of a product. So we attempted, or I say we, I mean the people and the groups who attempted to put the Medicines and Related Substances Act together were trying to be as prospective as they possibly could in an industry that could easily be over-regulated, but also that can be under-regulated, where we see that people are using medicines for incorrect reasons, or that prescribers are prescribing outside of their gambit, or pharmacists are acting outside of their their scope of practice. So that's why we have the Medicines and Related Substances Act. And then also to explain to people about the scheduling. Obviously, it goes into quite specific professional jargon, but it reads easily once you know what the basics are, and how we navigate those schedules.
Perfect. And I mean, I would like to highlight as well, I mean, the point of putting an act together like the Medicine and Related Substances Act is really to protect the consumer, often from charlatans, often to introduce standards that should be present in the place, not to have anyone professionally step outside of the boundaries. I know this is obviously a situation where we're trying to bring, let's say, cannabis into what would be a medical framework. Not to say it hasn't been in that space, because it was in the US pharmacopoeia for years prior to its prohibition. So, I mean, it's one where, for the sake, if we look over 200 years and longer, there's a lot of, use of the plant. And I think it's one where, at this point, it's just finding that balancing act between, how it will ultimately play out as more clinical evidence establishes itself in the space, and ultimately how to protect safety in the space. So I wanted to quickly jump. I noticed a bit of dogs in the background. That's completely fine.
Yeah, sorry, it's really noisy.
Can we discuss? Obviously, we had initially seen back in 2019 a release from SAHPRA in terms of how they were placed in scheduling, and then they updated it in May of 2020. Can you discuss, and I wouldn't say briefly, let's maybe discuss this comprehensively, the difference between something like a Schedule 4 and 6 product on the shelf, or not on the shelf? When we talk about on the shelf, we mean, in a pharmacy, secured away from the public. Only Schedule 1 and 2 perhaps will be an OTC, over-the-counter product, and Schedule 0 is completely available to be placed in any general store. How does a company, what is a Schedule 6 substance? And, just in general, if we don't talk cannabis specific, how does one go about getting that in place?
Absolutely. So I just wanted to add that the Medicines and Related Substances Act is when we look at products and medical or any product that's available, we look at quality, safety, and efficacy for the outcome of the patient. So that I want to highlight, and I will keep as much of a golden thread through as possible, because again, at the end of the day, quality, safety, and efficacy is what speak to the patient. So if we have to speak in scheduling status, most of the previously illicit substances, heroin, cannabis, and I don't even like saying the two in the same sentence because they're completely different. However, they were in the Medicines and Related Substances Act. They lay within the gambit of law enforcement, and they were under when we still had Schedule 9, Schedule 8, and Schedule 7. They were then in those tiers of the Medicines and Related Substances Act. So they weren't even ignored, even though they were illicit substances. They still had to be accounted for. So as you said, let's take away from the fact that talking about cannabis, we speak about a Schedule 6 substance. A Schedule 6 substance is kept in what we call an HFD, or a habit-forming drug cupboard, and a high formulation drug cupboard. at the back of any pharmacy in any space. So it's within a public healthcare space, private healthcare, a retail pharmacy, a hospital pharmacy. It's kept under lock and key. And the only person who has that key is the responsible pharmacist on site. And then possibly maybe the pharmacy manager, if they're a pharmacist, will then have a duplicate key somewhere. And that key is never, ever given to any other support personnel. The reason for that is that Schedule 6, so it has to be controlled, it has to be documented, it has to be balanced 4 times a year, and any auditors, an external auditor or a SAHPRA auditor or evaluator or we don't call them inspectors anymore, we call them compliance officers. They can come in at any given time into a pharmacy of any sort, of any description, and they can check your Schedule 6 register. And if it is not balanced, if you cannot account for any dismissed or product that has been thrown away, or not thrown away, but incinerated, then you have to explain why you can't account for that. Schedule 6 can only be given by a healthcare practitioner who is registered with HPCSA and who is allowed to do so. They don't need any other extra papers. So a GP, a pediatrician, a gynecologist, an orthopedic surgeon, a physician, anybody a healthcare professional who has done their prescribing course through their healthcare profession can prescribe a Schedule 6. So that I want to be quite clear about from the beginning. Even a pharmacist who has done a public healthcare course cannot prescribe a Schedule 6. We can only prescribe up to a Schedule 4 if we've completed and got that certification. So Schedule 6s are very controlled substances. They cannot be repeated on a prescription. I'm talking on a very granular level. The prescription has to be within 30 days of issue. So a patient who comes to a pharmacy on the 5th of August and their script was written on the 3rd of June, we are not allowed by law to honor that prescription. So that's just giving you an idea of how controlled that substance is. We then go down to the Schedule 5s, which are generally antidepressants, sleeping tablets, some biologicals. Schedule 4s generally would be hormone therapies, hormone replacement therapies, thyroid medication. They need to be controlled, but they are permitted to be, under certain circumstances, prescribed by pharmacists with a special permission or all healthcare professionals. These, at this point, I must say, are all kept within the dispensary area of a pharmacy or the dispensing area of a public pharmacy or outlet, so to speak. When I speak about pharmacy, I'm speaking as a generalized hospital, retail, commercial, public wholesaler. There has to be a paper trail of them.
Yeah, exactly. They have to be all monitored in terms of, when was it dispensed. And if we compare that, so if I'm going to use CBD as an example, CBD is Schedule 4 for the most part, unless it meets certain exclusions, as was gazetted by government. One of those exclusions relates to complementary medicines, where they specifically outline that the pack size for cannabidiol cannot exceed 600 milligrams for sales pack, and then obviously specification that the maximum daily dose is 20 milligrams. And that there's a low risk claim. Can you maybe, in that sense, what we are talking about is a product that can be sold, OTC, over the counter at any pharmacy. It can be sold even at, typically a Pick and Pay or any retail store. And then on that low risk claim, can you elaborate a bit about that and, that contrast between the two, Schedule 4 and Schedule 0?
So it's a massive contrast, Jeff. If you look at, so we just discussed a while ago, paracetamol. Paracetamol and, whatever the actual component, the trade name is, whether it's Panado, whether it's Calpol, it's Schedule 0. So it's available to everyone who can take it off of a shelf. They don't need interaction with anyone. They don't need advice from anyone. However, paracetamol in its own molecular state can do quite a lot of liver damage. So we have to be very cautious when we start stepping into these spaces of, just because it says Schedule 0 and that it's a CAMS or a complementary medicine, or it purely means that there are no substantiated claims or research. Now, I'm not saying this for paracetamol. I'm saying that the opposite. So paracetamol was fully clinically researched. It was allowed to be researched. It wasn't a previously illicit substance, but it was found that it required a scheduling and that it was safe within certain parameters. And that then relates back to the Medicines and Related Substances Act. A 14-year-old can't go in and buy as much Panado as they like. Well, they shouldn't be able to. Let me just caveat that on the side. However, when we start dabbling with Schedule Zeros to say, it's a CAMS product, it's complementary. What is it complementary to, and what is that complementary medicine advice or information based on? Are we saying it's complementary because we haven't got substantiated claims and we haven't got substantiated research for it yet? Or are we just trying to jump in on a market where something is a buzzword and we're not actually 100% sure of why we're doing it? And this is where the gray area in the industry becomes difficult. It becomes difficult for healthcare professionals to manage. It becomes difficult for patients and for the public to understand how healthcare professionals should be looking after their health. And it also starts creating a little bit of, if you could call it, discredit and doubt in a consumer's mind. So patient/consumer, we don't want them to be doubtful of the care that they're receiving or products that are on the market, because there might be sort of a Wild West approach to the fact that, oh, look at South Africa, we come so far with our regulations and we really need to get product on the shelf. But we need to be very cautious of the way we approach this in terms of substantiating products that are on the market. So Schedule Zero or complementary medicines essentially mean that they have found to have some form of benefit. And what I use here is the African traditional medicines. They've been used for hundreds and hundreds of years. We discussed it on a recent workshop that we had. And we had the African traditional healers, we had bush doctors, we had a lot of Rastafarian elders as well. And the amount of years or eons that these products have been used beneficially have been really well documented. I mean, we look at rooibos tea. Rooibos tea is not Schedule Zero. However, it does have certain antioxidant properties that have been researched and that have been proven. And this is where I go back to how we have to approach the scheduling and how we have to approach what we talk about and when we talk about it with CBD and with THC.
Perfect, 100%. And I fully agree. I mean, one of the things that, I know it's a balancing act for all parties in terms of we all want more clinical information so we can have a better understanding of not just CBD and THC, but all the components within the plant. So that work is somewhat taking its place internationally and with the Israelis and other groups. The question, obviously, for me, the more concerning point is things like the post-importation testing that is required around these products. I mean, who is going around actually testing these products that are on the shelf? I mean, that's a question I think we've both had for a very long time. And I know that
I'm laughing.
I'll do a call up. Yeah, I know. It's one of, but I mean, this is actually where it starts. For me, if we're talking about consumer safety and at least consistency, I want to know if I'm convinced based on my own research and literature and it's a Schedule Zero substance and I want to buy it for, let's say, helping me sleep, I want to buy a product I can trust. Now, do I trust in the international products? Do I want to support the local products? Are any of the products being tested? And I think we can both kind of lean into that one because I think we both know, working in the space, that unfortunately, there isn't as a stringent protocol for some of these being tested.
Jeff, you say it so diplomatically, and that's why I love our chats. And I'm laughing already because, I'm so glad you brought up the post-importation testing, because I think if ever I get a new tattoo, it's going to be on my forehead that says post-importation testing, because I'm a voracious supporter of anything that comes into the country. So we start on, like you said, let's exclude the cannabis conversation for now. And you want to bring in an API. It is no longer protected in terms of trademark or generic IP. It's older than 20 years, and you want to bring in a generic paracetamol molecule. You want to bring in a paracetamol isolate. You want to bring in a paracetamol excipient. You want to bring in some sugar from, I don't know, from India or something like that. Once that reaches the port, whatever it is, excipient, and it's marked for a wholesaler, a manufacturer, a third party, it will reach there with a certificate of analysis from that country that it came from. That certificate of analysis, I mean, you and I know, but for purposes of our audience, they need to know that it's basically an identification method of whatever that product is. And we can extend this, our previous conversation in Joburg with our other colleague, extended to traceability. And even if it wasn't a medicinal product, we still have to extend it for traceability purposes coming onto South African soil or into the country. So let's go back to our example. You want to bring this API or this excipient in. It's marked for a third-party manufacturer or wholesaler, and the certificate of analysis gives it an identification. So what is this product? What is in it? And what components of what are in it, at what percentage or what ratio? It doesn't matter. It basically gives an ID of what that product is. And if I take a bit of that product, I take a teaspoon or a vial or a container of that product, and I take it to my independent laboratory, and I ask them to test that. Whether FTIR, whether GC, whether HPLC, they test it according to what is most appropriate in a pharmacopoeia for that product. And then they also then print me a certificate of analysis. If I, as a pharmacist, you know already, I've spoken about it a lot. If I want to completely validate that, I can then maybe go to my own in-house laboratory and I can have it tested as well. So then we've got 2 South African tests, and we've got 1 certificate of analysis from the country of origin of the product. Within ranges, within stipulated ranges that are set within pharmacopoeias and in the regulatory biopharmaceutical environment, those 3 certificates of analysis must be within at least a range of each other. Now, obviously, each product has its own range. So let's say, for example, paracetamol, the COAs can be 10% out, for example, in a range, but they can't be 15% out. And then we look at, so that's just analytical identification, and then what is in that molecule or what is in that API. Then we have to look at specifically, very, very importantly in South Africa, is the microbial analysis. So what microbes are potentially or have tested to be in that product. Now, you don't ever get a completely 100% microbe-free product unless it's an injectable, which are done under very different circumstances. And the import of API for injectables also follows a different process in terms of supply chain. However, there are certain parameters that those microbiologicals need to fall within. So there'd be a sort of no less than 10 CFUs, which are called colony-forming units, which means how many colonies of that bacteria are formed within a certain centimeter space on when they do the Petri dish testing. So I'm going quite deep here, but it's just to give our audience an understanding of how microbiologicals are tested. So we have to look and see in that product, what are the microbials in that product, and do they match our microbial post-importation testing that we have done? And Jeff, you know, with respect, I've used this example before. I will tone it down a bit, but I honestly don't want to know that a product that I'm choosing to buy or using has been made in somebody's kitchen, garage, backyard, outside in the snow in Minnesota, with a very dirty pan, and they haven't washed their hands after they've gone to the bathroom. And that is very much, I'm not specifying in this industry, I'm specifying in any industry that we need to be aware of, is that how that product gets to that point of the port or gets to the point into our country is incredibly important in terms of consistent supply chain, consistent traceability, consistent tracking, and consistent certificate of analysis or certificate of conformance. For example, if it's an excipient and maybe a non-medicinal item, then it would be purely a certificate of conformance that this product conforms to the guidelines of what food grade sugar should be to be used in a sachet for indigestion. And Perfect. That is, it sounds very involved, but when you give it that last sentence, it's super simple.
Yeah, exactly. And I mean, for me, this is the thing. I mean, even if your product is being shipped from a GMP, which is a good manufacturing practice site that's fully licensed, it doesn't negate the responsibility to post-test. You know, when post-importation testing happens, the reason is a lot can happen during the transit. You know, the ship can stand on water for a few extra days, or if it's a flight, it could stand out in the sun for a couple of days. All of this can accelerate microbes being grown up in the sample, as well as deteriorate the actual active in that substance. So I completely agree. Like, the first call of entry really needs to be that decision to test every substance coming in addition, so that it complies, so that we know that what we're providing to, whether that's a contract lab or it's a finished pharmaceutical product that's going on a shelf, that it actually conforms to what it needs to meet. And I'd like to jump forward here a little, because, I mean, we've discussed this a bit as well, in terms of, currently, the way I see it and the way I've been told from different parties in the industry is, in terms of cannabinoid-based Scheduled 4 and 6 substances, at this point, it seems there is no full marketing authorization, or some company or party hasn't brought to South Africa an application where they have gone ahead and actually gotten a Schedule 4 or 6 substance. So Schedule 4 being a medically proven CBD product, perhaps like Epidiolex, and Schedule 6 being a THC-containing substance. And they haven't actually gotten an authorization for these products in the country. And for me, this raises the next point, which is a GP is within their full rights to go and prescribe, let's say, a Schedule 6 THC dosage, but if the patient cannot get access to it, we are kind of sitting in that chicken and egg scenario where it's great that we now allow the scope of Schedule 4 and 6, but if no one's authorized or gone through a marketing authorization, maybe you can tell us a bit about what a marketing authorization is, what maybe a CTD is, a common technical document. How does that all relate, and what is required, so that if someone goes ahead and an applicant files for this this application, it will actually enable doctors to start taking that next step, which is prescribe a Schedule 4 and 6 substance.
Yeah. So, Jeff, you nail the passion points with me every single time. Just when I think, okay, I can just sort of now just calm and just be calmly passionate about your industry. Boy, you come with and firing with the full passion questions. Now you've hit my full passion point, which is where the regulators are sitting with THC and CBD and how they're approaching it. And by no stretch of the imagination must we think that the regulator is sitting on their hands where cannabis is concerned. I think what is happening is that the capacity and the resource to address it fully is still being figured out. So I'll give you my professional opinion, and not to tell them what they need to do, but just to give an input in terms of where other Schedule 6 and Schedule 4 products align, as well as where we're now putting cannabis. And there is a misalignment, which I don't think is deliberate. I just think it is more of a protective mechanism as to where we are with the rapid rollover of the regulations that happened. I just wanted to mention, Jeff, one more thing on the last bit, is that chain of custody is incredibly important in terms of the integrity of a product. So you can't always be certain that there'll be a responsible pharmacist or a pharmacist or somebody at the Port Health receiving a product. So you have to have some sort of a chain of custody and an accountability partner or person who is responsible for checking your certificate of analysis or certificate of conformance at Port Health, and then whoever is receiving it on the other side is also part of that chain of custody. It's what we talk about in the industry, specifically with higher scheduled products. That chain of custody becomes really, really important. But in terms of the Schedule 6 and the Schedule 4, I'll give you a practical example, is that if any GP in South Africa is allowed to prescribe a Schedule 6. So you can go to a GP, you can go to a pediatrician, you can go to whoever your healthcare providers are and tell them of your condition, and they might need to prescribe you Schedule 6. Some of those common ones are methylphenidate. The originator, the trade name was, I know there's a couple of different generics now, but the originator was Ritalin. And then there's morphine, there's codeine, and then there's methadone, which they use in the rehabilitating drug and substance abuse patients. So you can hear that they're all really sort of not high end, but sort of high potential for addiction products, but anybody can prescribe them. So you can go to your GP tomorrow and say you have an extreme pain, or, for some or other reason you find you have morphine. Your GP is allowed to give you morphine because it's available here. If your GP can also write down Sativex on that prescription, but Sativex is not available in South Africa. So you as the patient will then need to go to the DG and to SAHPRA and to the company wherever overseas. It's a US FDA approved product, so it would be a US product. And you would then have to apply to get that product as Sativex as it is in. Because currently we do not have any Schedule 6 THC or Schedule 4 products in the process or in the entry level or in the system, so to speak, in that CTD triangle system, which I'll get to now, that are even remotely approaching an authorization. They're not even at the beginning of an authorization. Now, I have to say, in terms of caveat in terms of my my clinical evaluator position with SAHPRA, because I am involved in cannabis cultivation, I am not allowed to evaluate any cannabis dossiers at all. So I don't know, but I've spoken with SAHPRA, and SAHPRA also said on a public domain webinar that they don't have any products at the moment. So
yeah, exactly. That's public knowledge. Fully agreed.
It's public knowledge. So on the Schedule 4 issue, and that's possibly more where, so we've addressed the Schedule 6, the THC. You know, I personally and professionally don't think we should be tying doctors or GPs' hands further to say, well, you need a Section 21 to be able to prescribe THC. They prescribe any Schedule 6. They prescribe all the others without any other section, any other papers. Why must they need it now for THC? The only reason is that because we don't have any current registered, evaluated, and regulated THC product within the South African borders. Number one. Number two, when it comes to Schedule 4, if it's, for example, I'll take the practical example of Epidiolex, which has been proven, it's FDA, the first FDA approved. It's been rolled out in many of the other countries because it's FDA approved and been used in the 2 epileptic seizure conditions for small children. And in fact, some adults, they're doing some clinical trials in adults now as well. But that your GP can prescribe for you, can write down Epidiolex. You'd have to go through the same process because Epidiolex is only available from the US and only recently in the UK. And before it was available in the UK, I read a story of a mom who was trying desperately to get Epidiolex for her daughter, her 3-year-old daughter. And it was going to cost something like £4,500 per month for her to get it. Plus, she had to get special authorization to get a Schedule, well, when in our terms, a Schedule 4 to give to her daughter. Now, I think any person who has got any parents, sister, child, friend with a condition of any sort, and you could help them, I have yet to find somebody who would say no. So we start getting embroiled in a legitimacy issue in terms of we need products, we need people to start registering products. But in order for them to start registering products, they need to do relevant clinical trials, which are in the process, and universities have been able to start doing clinical trials. But because of the nature of the product, as it being previously illicit, those studies seem to be a little bit slower. So we're leaning heavily on the US market where they are a little bit ahead of us. However, the misalignment is in terms of marketing authorization is what I want to address. And I have alluded to it a little bit now, is that GPs are allowed to, as I said, prescribe Schedule 6s. They shouldn't need a special section to prescribe THC because it now falls under the same Schedule 6s as the other Schedule 6s I mentioned. It is no longer Schedule 7, 8, or 9, which is considered in South Africa an illicit substance. The recent UN ruling to take cannabis off the illicit substances list was absolutely groundbreaking in terms of good news for our industry. However, it doesn't mean that we can Wild West. Oh, the UN have said and they've taken it off. Let's all jump into the pool of the market without any rules and regulations. And this is where the eCTD, the documentation, it used to be a common technical document. So what a company would do is they would arrive at MCC back then. They would arrive at MCC's doors with a security truck, and they would unload maybe 10 to 15 boxes of paperwork, of clinical trials, of dossiers, of applications, of proof, of PKS, which is your pharmacokinetic studies, your PKDs, which is your pharmacodynamic studies, your safety studies, your efficacy studies, your dissolution trials. So everything that goes into making that drug credible is in those boxes. And you can understand with the advent of technology, it was required, and space, resources. You can't have, if you're doing 50 dossiers at a time, you can imagine how well those dossiers and document boxes have to be marked. If you look, you remember, I don't know if anybody watches CSI, but I'm a massive CSI fan. And I always used to love watching them walking down those rows and rows and rows of evidence boxes to revisit a trial or revisit evidence. And this is exactly what SAHPRA looked like, these rows and rows and rows of hard boxes of dossiers that needed to be pulled out. With that came what we call the slow process of tech transfer. So we transferred those documents to an electronic system and uploaded it onto a central, almost a central database obviously with controlled access, onto a database where these dossiers could then be accessed in an electronic format as if you were sort of going through a box of dossiers and a box of paper, basically, like a concertina file of information. And in every one of those, SAHPRA has got very, very clear guidelines. And this is where I respect and take my hat off to them in terms of the way they've approached their transition from MCC to SAHPRA, as well as their physical transition from a big 5 separated campus into a consolidated building. And within that period of time, they've managed to, I know lots of people have said, it's slow and the regulation is slow, but they've had all of this transition going on, and they've managed to do it as, I think, as smoothly as possible with as much chaos going on around them as possible. So we have to acknowledge that they've tried to maintain that traction whilst working in a bit of under-resourced and, to be honest, the pandemic process and issues. So the electronic common technical, sorry, yes?
No, I was going to say, just to add to it, I mean, a lot of misunderstanding does happen in the space. SAHPRA's role is really focused on medical products and not consumer products. And I think often,
Yes.
they do take a lot of heat because, people want consumer-based cannabis products. That's not been allowed for in terms of the regulatory framework. And in terms of a medicinal product, and specifically if I'm talking medicinal, I may be leaning a little more towards your S4 and your S6. This is exactly the amount of paperwork, the effort, the stability studies on the drug, the efficacy, all of this, the clinical trial data. This is really not something you can skate by and just say, oh, yes, we approve. I mean, we see this with the COVID vaccine that's in evaluation as well, that's recently in. I mean, this is a process, and there's a lot of pressure everywhere to accelerate these checks and balances. But there's a need for that because we're ultimately trying to provide the consumer a safe product. So I just want to support your statement there that, it is difficult. They've moved campuses 2-3 times in the last couple of years. So, to be able to consolidate this information, keep order, I've seen some good innovations as well from their space. So I support your statement on that. And obviously, continue with the eCTD, because this is obviously a very hot topic when it comes to Schedule 4 and 6.
Absolutely. So what I was actually saying, the kudos that I was going to give them is that they've been very hot on guidelines. So when something before something has happened, in fact, they have published guidelines. And then again, in the prospective nature and a rapidly evolving disruptive industry, they have done as much as they could. I mean, if I look at something as simple and straightforward, again, also it's public domain. So you go onto the SAHPRA website and look for a cultivation for medicinal cannabis application license. What it was in 2018 to what it is now, they have, amidst all the moving and amidst everything, their guidelines have become a lot more specific, and they've listened. If anybody wants to ever hear that a regulator is listening to the industry, you need to pull out the original cultivation license application and the updated cultivation license application. And that's where
I have to stop you there, because I did that actually 2 days ago, and I was comparing my old notes and the new one, and I had the same thought in terms of I'm glad to see the iteration and the need to go back. And I think they've taken guidance from industry in that regard, because compared to the initial one and the inclusion of other parties within government, I think now it's become a little more balanced, the approach. So absolutely, I support that statement.
So the fact that they have included and have listened to industry and all role players in the industry, I have to, if ever there was an inclusive in disruptive industry in terms of regulatory and professions, I mean, who ever thought we'd be speaking about cannabis innovation, inclusivity. You've got, Rasta guys sitting next to suit guys, sitting next to graffiti artist guys, and they're all speaking a different but a same language. So we must not forget that essence that it brings to, and maybe that's why I'm so passionate about it, because I've always been a consolidator and a bringing people together, if I can put it that way. And if ever there was something that brought people together in a true sense of the form, it's been cannabis. And I'm not speaking from the typical, the stigmatized, unfortunate, this whole whatever, pass the duchy from the left hand side or whatever it is. It is what it is, and it's an amazing entity that should be treated accordingly, and not sort of ripped apart into all these different. The picture I have in my head is this beautiful grown flowering cannabis plant that's being pulled all in these different directions, which it's not necessarily necessary, because it's not good for the plant and it's not good for the people that are around the plant who are using it. What I wanted to say when you mentioned, Jeff, about the being in the industry and having these guidelines, it's important that we remember the essence of it, and that even if something says it's complementary, or when you say you refer to medicinal more to Schedule 6 and Schedule 4, any product that you take to make yourself feel better is medicinally approached, if I can put it that way. Now, I know that can open up another floor of debate. So, well, if people take alcohol or use alcohol to feel better, is it a coping mechanism or is it a medicine? So I know I get that I'm blurring the lines, but I'm speaking from you go to a pharmacy or a wellness store and you ask for advice on what you can eat to make you feel better or to improve your diet, or what supplement you can take because you're feeling a bit tired, or you are taking it with the purpose and the intent of feeling better or making yourself better or making somebody else better. And that for me is the bottom line. So I just want to do, you need to rein me. I told you need to rein me in. Back to the ECTD.
I'll rein you in there. No, we're in full support of that. The one point I wanted to discuss as well on Schedule 4 and 6 was often, so I look at it also from the commercial perspective of the pharmaceutical manufacturer. In a country where it's completely legal within your constitutional rights to grow your own cannabis at home, it makes it also a very difficult argument for a commercial company when they look at, okay, do we file, if we, let's say, are GW Pharma and we have Epidiolex, do we do a marketing authorization or have someone sponsor that authorization in South Africa where there's ready access to the plant in its own private use? I mean, these are things that also are not often discussed, but it directly impacts on the Schedule 4 and 6 side of things, because, ultimately for those registered products to be registered with SAHPRA, they need to almost have a market, and there is a market for sure. But I think it's also often, compared in terms of the reality, which is someone going to pay this premium price for the product based on the fact that you can grow it at home? And for me, that's sometimes a bit of a pity. There's a pity in two senses there for me. It's one of, we do want minors to get access to prescribable quantities of precise dosing for therapeutic purposes, which a Schedule 4 and 6 is. It specifically has therapeutic claims, and it supports the evidence around that product. That will continue internationally independent, so I'm not worried about the strength and development of Schedule 4 and 6 in the cannabis space. I'm just worried in terms of that frustration that GPs must feel, that we often feel, that it's not that easy to go about, scheduling, writing out a script and say, here's Schedule 4 and 6, and go and get it at your local Clicks or Discount. And for me, this is a good and a bad thing of, of the if I talk from a medical perspective, I don't think it's a bad thing to obviously, allow people to do what they want in their own private space. And it's also a result of the frustration of the existing, medical framework that often is very intensive, like we discussed, the files and files that have to get approval. But I also want to just highlight that because the question might come up to the audience, which is, well, why is it SAHPRA's fault that this isn't happening? And it's really more of a commercial discussion. It's one of, just to highlight that point, that, it's not that easy. There has to be a market for an international company and for a local sponsor to kind of look at pursuing the introduction of these products. I do think it will be coming. I don't think this will probably be something that won't be too long to wait on, but it is obviously due to the fact that it's going to be more expensive, and the argument can be made that you can grow it at home so you can self-medicate. But again, self-medicate and directed medication are two different things, and we're very sure about that and the distinction behind that. The one thing I want to jump into now, because I want to keep us going forward here, is back to Schedule 0. So now, to everyone in the audience, Schedule 0 again is it's a general product like paracetamol at the counter. You can get it at pretty much OTC, over the counter, or at a general store. The claim that needs to be on often these products is the specific one I have up on the slide deck, which is this unregistered medicine has not been evaluated by SAHPRA for its quality, safety, or intended use. Now, I see this on products, but I also don't see this on a lot of products. Can you tell us a bit more about the background behind this and, to be on the lookout for this as a consumer and what it actually means?
Sure. I just want to add into what you said earlier, which will also feed into this this claim or this statement that is put on complementary meds as a default. One definitive that we have to be very, very sure of and careful of is that Schedule 6, so anything above Schedule 6, 7, and 8 currently are considered illicit products, substances, and are still under law enforcement. What we have to be cognizant of is that currently cannabis is the only Schedule 6 medicine that is still lying under law enforcement at SAHPRA. Now, in order to take away and remove and continue in a positive direction with the destigmatization of the enforcement of law on cannabis, it needs to move from law enforcement to a completely independent or a separate committee within SAHPRA. We've discussed this. I feel very strongly about it. There's a lot of other professionals who are citing and who are being alerted to the same kind of thing. It's no longer law enforcement because it's Schedule 6. It doesn't methylphenidate, codeine, morphine. They're not under law enforcement at SAHPRA, and they're also Schedule 6s. So that's where I want to just sort of say that the misalignments we have to be aware of and careful of, and I think that's what's prickling a lot of the industry people is that although there's been progress, cannabis has still got that stigma even at the regulators. So we need to be aware of that, and we need to push in a positive and a constructive direction to advise in accordingly to remove it from the law enforcement section. As far as your own personal use and your private use, that's also becoming a blurry line, Jeff, because if I know somebody's growing poppies at home, I'm not going to go to them and grab a bunch of poppies because the amount of processing that those poppies need to get to the state of either opium, cocaine, or codeine is so extensive that the output is not worth what the input is. And I know a lot of people might say, well, why are you comparing poppies with cannabis? Because they're both naturally grown products. It's the same as me sort of comparing it to rooibos tea or rosemary. Anything can be extracted out of it. We've just found that there are more beneficial components to it. The fact that the statement of unregistered medicine has not been evaluated by SAHPRA for its quality, safety, or intended use means that the product has been lodged. It has either been manufactured on a pharmaceutical premises. Insufficient clinical studies have been done. However, there is historical or other country data to reflect that it may be useful or beneficial to a patient. But that company specifically cannot say it and cannot claim it because they themselves have not done that study, that full gambit, that post-importation testing, pre-importation testing, API testing. They haven't done a full PKS or a full PKD on it. They haven't done dissolution studies on it. It's inherited, or it's historical data that they've used. And even then, you would be very pushed, and I don't want to say never, because it's a never say never, but you're not going to find a Schedule 1 or a Schedule 2 product that has got this statement on it, because Schedule 1 and Schedule 2 intimate that it has been, at the very least, produced, manufactured in a GMP and more facility, because remember, GMP is minimum standards. In a GMP facility, it has been packed accordingly. It's been packed on a line. It has been documented. It is traceable. It has a chain of custody. So we need to be very aware that these aren't, I can't say that they're rogue products at all. That's going very far out. But they are products that in the last, I would say, 5 to 10 years, have the intention was good for SAHPRA to allow for some companies to enter the market in terms of having a product on the market. However, it's like any system. I think it was strongly taken advantage of. I don't know if any of the audience or if you yourself remember the Lennon's product. So there were a number of Lennon's products that weren't even scheduled. And it was all the Bahut Middle and the David Traxel and swall seed and those kind of things. There was one of them that we actually had to keep behind the dispensary because it had, I think, 5% of opium in it, in an alcohol tincture. So even in my intern days, it wasn't even scheduled, but we as a professional collective always kept it behind the counter in order for it not to be misused because of that the opium that was in it. It has definitely been taken out of the product. It was recalled and it's been put back onto the shelves purely, but with this statement on it. So they had to repackage, they had to relabel, which is obviously a cost-intensive process for any company. But if you've got a foothold in the market in terms of a brand, and you want to maintain that market, then you will do what is necessary with the regulator in order to have that product on the market. So in terms of what you were saying about us having a Schedule 6 and a Schedule 4 here, I don't think we must blur the lines with personal and private use, because that is a separate regulatory or a separate issue that has been permitted. And I think in terms of constitutional and human rights is what we must focus on. But when we start talking about regulation and medicine, I think that there are two separate conversations. If you come to my house, Jeff, and you come for a braai or a dinner, I'm not going to come and bring my Schedule 6, not that I have it here, but if I have Schedule 6 morphine or Schedule 6 methylphenidate in a bottle, say, hey, Jeff, you feel like a Ritalin or you feel like a morphine, you know? I'm not going to come to you and say, hey, Jeff, you know, you're welcome. There's my plant. You're welcome to take a leaf of my rosemary or some of my basil or a piece of, there's bud or biomass there. But I'm not going to put out a processed Schedule 6 medication and just offer it to you, because first of all, that's not allowed within the Medicines and Related Substances or Pharmacy Act for that matter. You are actually not allowed to share medication with other people unless they're on the same medication or unless they're really desperate, or you are a prescribing healthcare official who can give them that medication. So I think we need to be very, very aware, and this also might be another topic of conversation that we can continue in the next session, is to discuss these anomalies, because that's 100%. Where I think the lines come in.
Perfect. I think, and with that, I'm going to push us a little ahead because I know there's some things we want to discuss. I think we've covered Schedule 6 pretty extensively. What I did want to highlight was specifically that, when it's an exception around THC, is I'll go back to this previous slide, and I'm going to use this as an example, the CBD oil. That's a Clex product. Now, I'm not, I'm just using it as an example, no, disparity or anything about it. But I take it you and I both refer to, and I think most of the industry refers to full spectrum to typically be a product that contains THC. Now, that won't be the case in this product. I think this is more just the use of the language. Usually we call it broad spectrum or compliant spectrum if we're referring to a CBD product or CBD oil that doesn't have THC in it. And in this regard, I would even be so cautious as to say compliant is not sufficient. It would have to be almost T-free, which is basically THC-free, because our limitations within Schedule 6 is in the 0.01%. So I'm very cautious of, labeling claims, specifications, things like full spectrum extraction. Essentially, the only way I can see this product constituted is basically a CBD isolate. And by full spectrum, it's the inclusion of things like terpenes, which could be plant-derived terpenes. And we'll discuss, cannabis-derived terpenes in a moment. But, I kind of see it as that's potentially what is inferred when we start seeing products that are trying to use, maybe they're using the words incorrectly. From a marketing perspective, it always sounds better to say full spectrum. But I think people need to just be aware in the public space that, traditionally, a full spectrum means everything in the plant. And if you're extracting from hemp or cannabis, there could be trace amounts of THC, and definitely at these levels present. Maybe you could get somewhere close to the 0.2 if you're lucky, and it's a really bad strain of CBD. But generally, there will always be some THC in the product unless we are refining that product to an isolate. I don't know what your view on that is.
So, Jeff, yeah, you touch on another sort of passion or pressure point for me is I go back to the importation testing. So, first of all, in terms of label claims, and we have to be super careful, because that first of all, there's a bandwagon jumping, because first of all, would you have looked at that bottle if it didn't have a cannabis leaf on it? Because cannabis leaves are the universal sign for, obviously we know, cannabis, the product. And so there's some bandwagon jumping, and not specifically this product. I'm speaking about everybody who's become involved in the space and potentially wants to benefit from the cannabis plant, whether good intention or not. But that full spectrum, you're 100% correct. Full spectrum implies that it contains everything and the full essence of the plant, from the top umbrella, I like to speak about the umbrella of cannabis, to underneath it being the indica sativa, and then further down THC, CBD, and then all the other endocannabinoids and terpenes that are in the plant. That full spectrum implies exactly that it contains everything of the plant. So if that's just telling me it's CBD oil, but it's saying full spectrum extraction, it means that oil was extracted from a whole plant. I know that the manufacturers would probably differ with me and would have a reason to differ with me, but they're now blurring the industry with what is full spectrum and what is not. Full spectrum, finished and klar, is the whole plant. Even if it was from hemp oil, because hemp by definition has less than, I think, 0.03%. Hemp is defined as less than 0.03, in fact, negligible THC in it. And I go then back to the post-importation testing, because if money needs to be spent, and even if that isolate was imported and then reworked or reprocessed or remanufactured on South African soil in a GMP facility, it would still have to have a COA. It will still have to have a certificate of analysis no matter what. And that certificate of analysis must tell me that there is CBD in it. It must tell me that is 0.000 to whatever decimal space the analytical laboratory tests on is in it. What the dispersible or the miscible oil is, or whatever the substance is it in it? Are there preservatives in it? How has it been stored? I recently did a research project on the effect of UV on cannabinoids, and over a period of 12 months, there was a depletion or a reduction of from 5 to 3% of THC alone in an amber bottle THC product. So, product stability comes into question. Where are the stability studies, and how can you do stability studies on a product that has not been around for that long? And I understand in terms of Schedule 0, you can put a product on the market and then still do parallel stability testing. but that requires reams and reams and reams of paperwork or for ECT documentation. You yourself know, Jeff, you've been involved with the COVID vaccines and the testings. How would you get a COVID vaccine onto the market without having stability studies in place? So, we have to be really, really, really specific and unfortunately pedantic if we want this industry to be sustainable and with a very end result of our patients still benefiting, and not just a big industry benefiting from patients looking at finding a cannabis leaf on a product and taking it. So there's lots of layers, there's lots of rabbit holes. I do hope enough for us to continue lots of sessions and discussions in this manner, because it's very necessary. It's necessary to educate our healthcare and our consumer population. Jeff, you know how passionate we are about this, and how many questions a day you get, how many questions a day I get. Healthcare professionals, bodies of healthcare professionals have phoned and said, what do we do? They've put CBD oil on our shelves. How do we sell it to the public with the confidence that this is what it says it is? And I had somebody phone me the other day, and I said, ask for the COA, ask for the certificate of analysis from where you got it. Oh, but that's just it's not a long process. It's a quick ask for, where is your laboratory test? Is it just analytics? Is it just microbials? In fact, I would, please, Lord, let it hope be both. But ask for the CA. And then the second line is the educating your staff in selling it. Just because it's got a pelargonium leaf or a peppermint leaf or a cannabis leaf on it doesn't necessarily mean that it's for you. And then if it's not for you, who can you ask that it is for you? And now we're talking about an education of a healthcare professional system that needs to know what they're giving their patients and the outcome of their patients at the end of the day. I say I can only speak about myself in terms of the cancer process. I didn't want to just get a thick dab of FECO for my post-chemo nausea and my post-chemo pain and my continuous chemo pain from anybody, just somebody's granny's, aunt's, uncle's, sister's brother down the road. I didn't know how they did it, how they grew it. And that's when your patient is vulnerable. And obviously I'm talking of an extreme vulnerability, but everybody experiences their conditions in a different vulnerable state. Even a child who has got flu or has got asthma or has got allergies, or a child who has epilepsy, or an adult who has hypertension. They in themselves feel vulnerable because they're not well. And we don't want to make them feel more vulnerable because they don't have security in where their product is coming from.
Exactly. And I mean, to that point, I mean, I'm glad you brought up the UV degradation. I'm a passionate advocate of stability. I mean, we've seen it in the COVID vaccine rollout. I mean, part of the reason that a lot of those vaccines have to be kept so cold in the logistics chain is because they haven't been able to lyophilize, which is basically freeze dry what would typically be a vaccine preparation, so it could be resuspended and administered. There hasn't been time to do they're doing emergency use authorizations with only limited stability data, and that will continue. And I mean, the formulation will improve and the delivery will improve, but stability is often that vital endpoint of, you need to make sure, if I'm going to make any kind of shelf life claim or inform a shelf life claim on a product, I need to put out some stability data. I need to test it for the climatic zone it's going to be sent to. I need to make sure that that product is stable, that if it does degrade, it doesn't degrade in excess of 10%, depending on how you see certain monographs. But it's one where absolutely, I mean, we could talk all day about it, but I'm going to move to the next topic because it's about that, because what does it degrade into? And what are the therapeutic effects of those degradants? Because, it could go to CBN, and CBN might have a completely different biophysical effect on the body and biochemical effect compared to your initial CBD. And this is the kind of thing that, as these products get more established, as more clinical data comes out there, as it gets more formalized in the space, pharmaceutical as well as commercial products will increasingly get better. And I mean, the big topic for me has always been the testing and the call-up. And I think, there needs to be this big push on, I think it's it's mandatory very soon that, you know, products are pulled from shelf and tested. And on this point, I'm going to bring us into possibly the second last slide of discussion. I know we're talking long, but it's a really impactful conversation. So I want to keep going on this topic because, you know, they say CBD is treated as Schedule 4, except when it's complementary medicines or under Schedule 0. So I have a question about infused products like honey. So honey is very naturally, you know, it's often considered loosely as a medicine. You know, it has biological, it's very healthy for you, depending obviously on certain limits. But I want to discuss the fact that what's your view on something like this where we have 10 milligrams of CBD, allegedly, because I'm going to preface that because I know how hard it would be to actually formulate this product with an even distribution, because honey and, you know, if you were using isolate, it would definitely, yeah, it's definitely a tough one. I mean, I would advise distillate, if anything, for the formulation here. So I'm sure if I pull this from the shelf and I start testing this, I'm going to have some concerns in terms of distribution. But in terms of your view as a responsible pharmacist, how do you see this jump on the bandwagon of natural health goods? Should there be more guidance specifically on infused products that's maybe addressed next by SAHPRA? Because I feel this is becoming quite a hot topic.
Yeah, it's becoming a hot topic, and it's becoming the Wild West for the Mavericks, Jeff, if I may just speak out of my space a bit, because as passionately as I feel positively about it, there are elements that I'm not saying specifically this, but could do harm to an industry that wants to be sustainable. So my first reaction to this is, well, the CBD bandwagon has become huge purely because the CBD component of cannabis is said to be non-psychoactive. So now we can slap CBD on any product because it's safe in inverted commas. But by whose standards is it safe? You know, quality, safety, and efficacy. Is it safe because it's non-psychoactive? But, you know, honey is safe, but not for children under 1.
Yeah,
so
and actually, I want to jump in there.
I have to call.
Yeah. Yeah, I have to jump in as well, because I mean, I've seen this point, and it's not a popular point, but what I want to mention is CBD does actually affect the central nervous system. So in some regards, it's still a psychoactive product. And you know, it's so easy, and I know we've done this before, and I know highly respected individuals. So it's a technical point, but it's one way I want to just highlight as well is it is psychoactive. It's just non-intoxicating, which is more the appropriate jargon. But again, I see on this label claim, and this is what perpetuates it, is that unlike THC, it has no psychoactive effects. And that's actually fundamentally not true for CBD, because why would you take it if it didn't have a central nervous effect on your central nervous system? So, I mean, these are the kind of uses, physiologies. This will take time. I know what is intended when people say it's non-psychoactive. Completely agreed with that intent. I've done it myself. We do it constantly. But again, it's this type of need for label claim review, assessment of this, that kind of needs to start being, I don't know if it needs to be published, if it needs to be put out to, you know, from the regulator in terms of how and what can be said, maybe more specifically. Is that too limiting from SAHPRA to do such a thing?
No, so this is skirting the line because it's a food product, and you know, as you know, SAHPRA only deals with medicinal products and devices, and this is where we've got the Maverick, and we've got the Rogue, and we've got the Wild West. At some point, because it's as a Schedule 4, it is still a medicinal product. SAHPRA would have to have an entity or an independent committee or officers who are able to address these food issues and beverage issues. So first, as you say, first and foremost, to say non-toxic substance, okay, non-toxic, I kind of dispute, because honey in itself, whether it has CBD in it or not, can be toxic to children under the age of 1. So there already is a label claim that is pushed towards the CBD, but is not taken the whole product as an entity into account. And to say non-toxic is, if I test that in an analytical laboratory and I find an aflatoxin or I find a pesticide, how can you still say non-toxic? Where is the lab report on this honey? I want to see a certificate of analysis or a certificate of conformance, or I want to see some form of proof that with every product I have, any product I have in my cupboard or my shelf or my fridge, I want to know that there is a certification process that has gone into it. Don't slap it on your label, certificates available. That means nothing. And then also, unlike THC, so now we want to support the industry, but we want to keep THC the baddie because we want to sell our CBD. So the wording, unlike THC, it has no psychoactive effects. There are CB1 receptors and CB2 receptors along the central nervous system pathway. We know that, and we can have an endocannabinoid discussion another time and where the CB1 and CB2 receptors are placed. The fact is if this does have CBD in it, it's going to affect the CB1 and CB2 receptors, which are both in the central nervous system and non-central nervous system. The other biggest issue on first sight, sorry, there's a bit of commotion in the background. I hope it's not coming through too badly.
No, perfectly fine.
The other thing that, I didn't even look at this for 2 seconds, this label. And, it's the trained eye, it's the professional eye. However, it says there at the bottom, fully certified. Certified for what? Fully certified as a honey, fully certified in terms of food grade, HACCP, TACCP, and VASCP, fully certified facility, and then it says 10 milligrams per serving. Where does it state what size a serving is? Do I dip my finger in and it's a serving? Do I give my 12-year-old a teaspoon? How much is in a teaspoon? If my 12-year-old wants to put this honey on her toast, what serving is she going to put on her toast? She's going to ask me because she lives in our household. She's going to say, Mom, this honey says CBD on it. Can I have it? And if I can, how much can I have? Should I have? May I have? And again, I know we've come across this, and it's no picking on any kind of product. We don't know who the product is, but I really, really, really need to pull this label apart in terms of regulatory and consumer information and consumer protection. This under Consumer Protection Act, this is not even skirting a line. This is falling into the muddy water. Because
exactly, and I've retracted the client's information on the honey as well. But it's not the first time, won't be the last time that we see this. And I think this was part of the reason we wanted to go this long on this conversation is that, if you're going to put products out to the marketplace, I almost feel that you need to assess it in terms of 2 things. One, am I doing the best interests in terms of the consumer? Sure, you're trying to do this to make a profit, I anticipate. Maybe that's the reason. But you've got to protect the consumer, and you've got to be ready for some form of recall in terms of if this product is pulled up, is it tested? If it fails testing, what does your liability around that look like? Because it's really just taking an opportunity and playing on a very dangerous slippery slope. And I think we need to talk about this as a community, as a profession, because I agree with you. It falls within food, but that's where a lot of these products are going to start falling in the coming weeks and months. And I think it's really important that discussion that SAHPRA or appropriately allocated authority starts going to retail stores, starts picking these, and this is a major retail store where I saw this. So it's not like it's just a mom and pop shop at a flea market. This is commercially what I would consider one of the top 5 food retailers. So it's one where if this is going to be on the shelf, who's checking that for label claims? Because this is something that has to almost be addressed in the next few months.
So my thinking would be that the food retailer would have to have a buyer for that to get onto the shelf. And what accountability does that buyer have to their affiliation of their major commercial store? And who then picks up the liability? And I will almost put my neck out on with good money is that retailer will pick up that liability because they've agreed to have that product on their shelves selling to the consumer. Consumer's not going to go after this company. Consumer's going to go after that big commercial. That big commercial will then would totally withdraw, should withdraw product from market, and then the questions need to be answered. And the biggest issue is what you were saying is the recall and not even the rework yet. The recall, we had the other day, because of the nature of healthcare professionals, if there is any recall of any product, it has to come out to all healthcare professionals at the same time. So everybody, all pharmacists, all GPs, all direct wholesalers, distributors, all receive an email and a letter posted to their post boxes of any recall. And the most recent one was of a long-standing company, of a long-standing product that had a full recall of, I think, 3 batches, where it was, and it's a well-known API. I mean, it's been used for ages. And they had a recall because of those particular batches. There was a problem with some of the excipient. Now, when I say excipient, I mean the inert product that makes up the rest of the tablet. So the lactulose, the powder filler, it's nothing. None of it has got medicinal properties. However, because of the irregularity in it, the dissolution of the drug in the body was increased to double, and it caused QT prolongation in heart patients. So QT prolongation, when we talk about it, you have your very quickly, you have your heart waves, your heart wavelengths, and the main one that keeps it beating properly and rhythmically is the QT section. And if the QT section beats slightly longer, so you measure the difference between the waves, and it causes QT prolongation, you have an extra additional possibility of increased myocardial infarction side effects.
Yeah, exactly.
And that's not light stuff. That's heavy stuff, because somebody is going to have a heart attack from this product that they're taking to prevent their heart attacks. So,
and it's crazy to think that that's from an excipient, let alone an active in that product.
Well, I mean, it was the product we were discussing the other day, or yesterday, about the 1967 Australian study. It wasn't the API that was the problem. It was the excipient that was added into the new generic, and the half-life of the product was halved, so it wasn't staying in the body long enough to prevent seizures, and everybody on it was having double the amount of seizures that they'd ever had before.
Yeah.
So
exactly.
We have to be very careful, and this is a perfect example of what is going to not destroy, but really is going to negatively affect a potentially sustainable and very good industry. These people need to be way more careful of what they're doing.
Exactly. And I mean, I would like to just highlight, I mean, we're not here, I mean, we're probably the most proactive in terms of pushing for product safety and getting products to the shelf. So we've all, to anyone listening as well, like, we want to see products come to shelf. We absolutely are driven by this. I mean, I would love nothing more than to see a Schedule 4 and 6 marketing authorization successfully done. I want to see these products come to shelf. But we need to just inform the public and insist on the need that you do it correctly. Just do it right so that the industry builds a great brand for professionalism and accuracy of information so that there is no liability. And I'd rather discuss this in a format like this where, we've attracted a company, we haven't thrown any stones in glass houses. We're kind of saying, listen here, this is what you need to be on the lookout for. Hopefully, a company like this would pick it up, or someone else is releasing a CBD-based honey. They'll be like, oh, wait, before we go to market, let's be sure about the solution that we see, or the mixture of the CBD in the honey. Let's be sure about our serving size specification. Let's be sure what we mean when we say fully certified. Maybe we should do some additional testing. And that ultimately is increasing the standard. And what we are both in complete support of is seeing products increasingly go to the consumer that have that increased safety efficacy, because we want to build the industry. That's what we're both doing. So for me, I just want to highlight that. And then I want to close off with, I know we've really run long on this, but it's such a good conversation for me. So I know that with obviously Schedule 7, cannabis was removed from Schedule 7 along with THC. And this brought up a lot of questions for me, because they've rescheduled THC and CBD, but they've kind of omitted clarity, for my view, unless it's somewhere else, in terms of cannabis-derived terpenes and other minor cannabinoids like CBG. Where does that fall in this scheduling? I mean, I know there's plant-based terpenes, because terpenes, for anyone who doesn't know, and I'm sure you will if you're on this type of a discussion, limonene, when you squeeze a lemon, it's that smell. So there's a couple of the terpenes out there. They definitely, I would say there's strong evidence to support its direct effect on the entourage effect in terms of what it provides to, if we use the old terminology of sativa and indicas, they have these certain terpene profiles that are maybe more common to them, that have a certain pharmacokinetic type of effect. But, for me, the question is, in terms of cannabis-derived terpenes, is it legal or illegal to bring it into the country? Because I don't see it in any scheduling presentation from SAHPRA.
Jeff, you raise again another fantastically great point, and I want to just also resound and resonate what you said about any listeners, to this. You have to know that anything worth doing well is worth doing properly, and this is why we're doing this. We are strong, forceful advocates for the industry, but we just want to make sure that we do this properly. That's all we want to say. We're not sort of degrading anybody or anyway. So yeah, the terpene question is intense, and you're right. There has been no scheduling assigned to the terpenes purely because they are considered to fall under THC and CBD and form that very specific, unique essence of what cannabis itself is. And I have to disclaim at the beginning of the sentence is that I'm a purist. So in terms of extracting very specific individual terpenes out of cannabis, I'm not entirely certain or convinced that I'm a fan, because it's taking away the essence of what cannabis is. I would understand why people would want to do it, but limonene is available in lemon rinds. Alpha pinene is available in pine needles. Beta caryophyllene is available straight from black peppercorn. So why don't you go and take it from those entities rather than dabbling around with cannabis and disrupting the essence of what cannabis is? So I'm just that's my personal opinion. Professionally, yes, you're correct. There's been certainly no external evidence given to the public that they're working on terpenes, because I think that's just another layer that is not top of the agenda at the moment. When I say agenda, I say it loosely. I don't say it in a derogatory way that somebody's got an agenda. I just don't think, in terms of priorities where cannabis lies, terpenes have formed a conversation. I know that they are coming in. However, I go back and I circle back to post-importation testing. It has to. I don't care if it comes in the tiniest 1 milliliter little tube, or a big isolate, or a big bottle, or how it comes. It needs to be tested. Is that terpene that's coming in? It's beta caryophyllene. What is the source of the beta caryophyllene? It was this strain. It was extracted by this means, and this is what it's supposed. This is the percentage of the beta caryophyllene that is in this concentrate or this isolate. Fine, we'll test it on our side. Our COA must match your COA. We'll bring it in, and then we can start putting it into, we can say beta caryophyllene MCT oil, because beta caryophyllene helps with inflammation and with pain. So it's a long answer to a short question, and maybe we can have another session just on terpenes, because themselves are fascinating.
Absolutely. I'm hoping there's more evidence. I'm sure there is. At this point, I'm sure there's a lot of studies on terpenes, because there's definite medical benefit to terpenes.
Yeah, absolutely, but not local at the moment.
No, and that's the thing. And one of the things that's going to be the hardest around terpenes is we discussed stability regarding the cannabinoids. Terpenes are the most volatile, chemically speaking. So stability studies around terpenes and establishing it in a what we'd call traditional Western type of approach, that's going to be a tough one. There's going to have to be some considerations, some ways to manage that. But we've had an amazing chat. Thank you so much. We've definitely run over time. That's for certain. But I think it's been, I'm sure our audience would agree they'd like us to continue continue to discuss this. The things I am interested to see going forward is, how does the UN vote to remove, Schedule 4, cannabis out of Schedule 4 from the single conventional narcotic drugs? How will that impact on local policy and future SAHPRA policy? It's going to take some time probably to work its way in, but it is an interesting and a very positive development. So I'm happy to see that, and we've alluded to it in the discussion already. And I'm also interested, just from a safety perspective, these CBD call-ups that are going to be done on products, taking products off shelf and testing. I think that's good for the industry. I think it's good for any mature industry to test products, to confirm what's in those products, and then to provide, findings and say, listen, there's a problem with this product. Either you fix it or you take it off the shelf. That is progress. I see that as progress in the industry, and I think it's something that should be aspired to, not feared. I think even in the US, there's a lot of issues in the US, even with call-ups of products and testing where it's underreported or absolutely nothing present in those products. And this is going to, the worst thing for me is when something like the plant is misused in terms of, we try to jump on the CBD bandwagon, users use it, they get no benefit because there's no CBD even present in the product. And then it just tarnishes what is a great medicinal plant. And I think for me, that's really why, I'm big on seeing more testing as a whole in the space, just because we need to know what is in our products. And Jacqui, thank you so much. I know you've really just, you've been an amazing source of discussion and resources for me as well in the space and for others. I've put out some channel discussions before on extraction, on GACP, on quality testing for international export, on GMP standards, the difference between pharmaceutical, food, and dietary supplement. Jacqui is a very proactive speaker, so we've been at several conferences together, and we probably will be in the course of 2021. We're doing this webinar a week before Christmas, so I think that shows our level of commitment to getting content out there. Jacqui's not always available on the phone, but you can try her. If not, I know you're very good on email, Jacqui. And then I'd like to ask you for any closing comments from your side. If someone were to reach out to you, where's an area that you really feel most passionate about assisting to maybe give them some guidance?
Jeff, thank you so much. Yeah, may this relationship and these series continue and grow and evolve as we've discussed. I just wanted to make one sort of last comment about what you were saying about stability and about terpenes. We talk about a lot of stability and product longevity, and it's important to know that most products degrade to nothing. So if you take an expired medicine, there will be no effect. However, one of the drugs, tetracycline, it's an antibiotic. If it's left to expire, it actually becomes dangerous. And what often happens is that THC will degrade to THCA, which is the psychoactive component, with heat and without enough stability and looking after. So we've got to keep that in the forefront of our mind. Jeff, thank you for the relationship thus far, and thank you for including me in what you do. I'm a strong supporter and a voracious supporter of you and what you do and how you do it. And I'm happy for anybody to reach out to me, preferably on email. My turnaround time is normally about 24 hours. It's a little bit slow, but I will get back to anybody who has questions. I have a strong knowledge and passion for cultivation, for analytics, and for use in chronic conditions such as cancer and post chemo nausea. But generally, one word that is my passion is cannabis and doing it right. So thank you for allowing me this voice. I know I probably wouldn't have had it if you hadn't have approached me. So thank you so much. And I really appreciate the involvement, and I appreciate your dedication to these projects, as you say, a week before Christmas, and in the madness that is. So thank you very much.
Thank you so much, Jacqui. And again, I appreciate you making the time, because this has been a phenomenal discussion. I think it's a much needed conversation. So I'm sure we're going to discuss this again. There's a lot to go into, and I definitely would encourage anyone with questions, reach out to us. It always edifies us in terms of getting better content out there to the public domain. And that is our objective. Our objective is just to communicate to the public domain, because it covers investors, stakeholders, regulators, international parties. We just want to make sure that the South African industry matures and grows and formalizes into a space where everyone can benefit and everyone can really utilize the most benefit from the plant. So thank you so much. Cheers, Jacqui.
Thank you, Jay. Have a good day.
Thanks. Have a good day.